Continuing with the station of pain management, so this is part 2 of the pain management. So what do you know about patient control analgesia PCA? It's a syringe in a locked container for intravenous infusion of self-administered boluses of morphine. So in this, as the name shows, the patient control. So patient control it by itself. Lockout time 5 minutes, which pressing the button again will not result in a bolus of analgesia. So what is lockout time? Lockout time is the time during which if patients repeat the dose or press the button, he will not be delivered with the dose. So he cannot repeat the dose in the lockout time. So that's why it is this is to prevent the overdose. So overdosage. So fixed dose overdosage is avoided by limiting both the size of the bolus and the frequency of administration. Patient has to actively press the button by himself. Acts as one-way valve. Can be reprogrammed for special situations. So if the patient is not getting proper analgesia with that specific dose, so you can change the dose level. Normal dose of morphine PCA 0.5 ml equivalent to 1 milligram of morphine. Okay, so this is the usual normal dosage 0.5 ml or 1 milligram. What are the limitations of PCA? So patient factor and pump factor, pump failure, IV line failure, IV set failure. So this can happen like this is instrument or like the machine factors. And patient factors are patient has to be alert and oriented to be able to use it. Sleep disturbance, and not suitable for patients who are confused or who are unable to press the demand button for physical reasons, limits patient mobility. So these are the limitations. Then like we have patients which are like very weak or critically ill, so they cannot use it, or some other reason, paralysis. So patient is sleeping and then suddenly he starts feeling the pain, so sleep disturbance is also associated. And it can overdose the patient as well. For example, patient is continuously injecting the doses, so he can be overdosed. What are the complications of pain? So CVS. These are the different systems which can be affected by the pain. So in cardiovascular, you can have the increased heart rate, blood pressure, myocardial consumption, increased myocardial consumption. So we can have MI, duty from immobility due to pain, anxiety, agitation, incompliance to treatment, decreased mobility, increase stress response, delayed gastric emptying, reduced bowel motility, paralytic ileus atelectasis due to hypoventilation, pneumonia, cough due to retained secretions. How would you manage his pain initially? So the patient which is given in the scenario, after ABCDE assessment, I will assess the severity of the pain with one of the pain scales. Then I will consult the pain team if available. If no pain team, then I will give analgesics according to WHO analgesic ladder with the regular assessment. Non-pharmacological methods: preoperative explanation, education, relaxation therapy, hypnosis, cold or heat, splinting of wounds, transcutaneous electric nerve stimulation, TANS. So these are the non-pharmacological methods. Like you can consult the patient before the surgery or operation that you will feel pain afterwards, so you don't have to. So patient will be mentally prepared. Pharmacological methods are simple: analgesia, paracetamol, NSAIDs, opiates, local anesthesia, epidural, and local infiltration. Give examples of opioids in common use, which agents are synthetic. So synthetic, non-synthetic, and semi-synthetic. So synthetic is pethidine, fentanyl. Semi-synthetic is dimorphine and dihydrocodeine, and non-synthetic is morphine, codeine. 10% of this is metabolized to morphine. Why is codeine bad? It can cause drowsiness, constipation, itching, nausea, vomiting, dry mouth, miosis, orthostatic hypotension, urinary retention, euphoria, dysphoria, and coughing, rare anaphylaxis, seizures, acute pancreatitis, and respiratory depressions. So these are the general complications of side effects of opioids. And cytochrome P2D6 P450 enzyme converts codeine into morphine in the liver, not fully, only the 10%. Some patients ultra rapid metabolizers, yes, who have a high level of this cytochrome P450 enzyme, so resulting in rapid formation of morphine in them, causing life-threatening intoxication, including respiratory depressions requiring intubation, can develop over a matter of days. Other patients, 10% lack this enzyme, they lose the analgesic effect of codeine, poor metabolizers, but suffer its side effects. So those who cannot who are slow metabolizer or poor metabolizer, who cannot metabolize codeine into morphine, so they cannot have the privilege, but they will suffer the consequences or the side effects of the codeine use, which we discussed earlier, like drowsiness, constipations, miosis, and euphoria. Considering moderate pain and a patient seeking analgesic. Considering moderate pain and patient seeking analgesic, what instruction will you give to nursing staff? No need to call pain team, anesthesia team at 10:30 p.m. So you don't have to call so they will give the scenario timing as well, that like it's late night 10:30, so you cannot call the anesthesia team or the pain team at that time. So to give 1 gram IV paracetamol, I will tell the nurse that there is no need to inform the pain team and anesthesia team. You just give 1 gram IV paracetamol, give full dose of morphine, 10 milligram IM subcutaneous or IV. To give omitted dose of paracetamol, and if can take oral, give diclofenac as well. So you have mixed these like paracetamol, diclofenac, and the analgesic opioid as well, strong opioid, because it's moderate pain. If the pain is not settled by above advice, I will address pain administering more morphine and contact anesthesia on call for further advice. I will examine the patient to identify any underlying cause. So first you have to assess the patient for any other reason, and then you can give more morphine, like you can increase the dose of morphine, and you have to inform the anesthetist or seek their help. What is the mechanism action of paracetamol? Paracetamol is a weak inhibitor of the synthesis of prostaglandins. Same like it says, however, the in vivo effects of paracetamol are similar to those of selective cyclooxygenase COX-2 inhibitors. Manage paracetamol toxicity. So paracetamol toxicity, first you have to do gastric decompression, gastric lavage within 30 minutes, within 60 minutes of ingestion, activated charcoal 30 minutes to 2 hours of ingestion. So you can lavage the patient with the activated charcoal, and then you can give the antidote and acetylcysteine. So basically what happens that paracetamol produces a very toxic metabolite, benzo, something like that. So it actually eat up the glutathione. So N-acetylcysteine. So it, since the paracetamol metabolite eats the glutathione, so it will. Glutathione is a antioxidant, and it protects the cell from the reactive species. So it will when there is no glutathione, there will be the hepatocytes will die, and it can cause center necrosis. So by giving an acetylcysteine, actually you are giving glutathione, so it will help out. Liver transplant in acute liver failure, fulminant failure. How does NSAID work? NSAID block arachidonic acid metabolism by inhibiting cyclooxygenase enzymes COX-1 and COX-2. These block the synthesis of pain mediators such as prostaglandins, prostacyclins, and leukotrienes. So, pain mediators are prostaglandins, leukotrienes, and prostacyclins. So, you basically arachidonic acid metabolism pathway by inhibiting the COX enzymes. What are the symptomatic side effects of NSAIDs that the consultant may be concerned about? So, splitting these up into systems, they include GI, renal, and cardiovascular coagulopathy, bronchospasm. NSAIDs can also cause dose-related increase in sodium and water retention. Yes, because they inhibit the prostaglandin. So, sodium water retention and COX-1 inhibitor leads to arachidonic acid being metabolized to leukotrienes, which can induce bronchospasm. So, yes, GI dyspepsia, gastritis, peptic ulcerations because of the blockage of the prostaglandins. Renal may precipitate acute renal failure because they cause vasoconstriction of the vessels. The renal vessels they cause vasoconstriction, and this can cause renal failure or use of long-term use. Cardiovascular salt and water retention can precipitate and worsen heart failure. Coagulopathy, inhibition of thromboxane A2 produces leads to a reduced capacity for platelet aggregations and therefore formation of the primary platelet plug. So basically, this the dysfunction the platelets, and aspirin is the only one which causes irreversible thromboxane inhibition. The rest are irreversible. So this was all about the pain management.